Welcome friends. I am Dr. Baldev Prajapati, Professor Emeritus and Director, Medical Education and Research, Baldev Medical College and Hospital Kadi, located in North Gujarat. These are my 4 books published in the field of pediatrics, particularly on procedures, signs and symptoms, clinical pediatrics, and very specific on OSCE, spotters, and viva. This is the institution where I am working at present. Today I am going to talk on the pallor. Friends, you will agree with me that pallor is a very common symptom and sign in the pediatric practice. The most common cause for pallor in children is anemia, but pale appearance may be seen in some other conditions as well, which should be kept in mind. Let us see what are the causes of just pale appearance. It may be most common due to the anemia, but sometimes may be due to the poor perfusion, the critical situation like shock, and that is due to the peripheral vasoconstriction. In a nephrotic syndrome, the appearance is due to the edema, while pale appearance may be in a case of congestive cardiac failure, again due to the poor perfusion and peripheral vasoconstriction. Vasovagal syncope, yes, child is looking quite pale, and somebody may feel it is due to the anemia. Hypothyroidism also is another condition where just you may feel the pale appearance. Friends, let us see that how we define the anemia. Anemia is defined as reduction in the oxygen carrying capacity of blood due to reduced hemoglobin concentration and red cell, that is hematocrit, leading to tissue hypoxia. What are the WHO cutoff values for diagnosis of anemia at different age group? In newborn, if hemoglobin is less than 14, it indicates anemia. 3 months, it is less than 9 gram. 6 months to 6 years, it is less than 11 gram per deciliter. 6 to 14 years, less than 12. Adult males less than 13. Adult females less than 12, and pregnant women less than 11 gram per deciliter. Let us see how we grade the anemia. Mild anemia, that means hemoglobin is less than 10 gram per deciliter. Moderate anemia, that means hemoglobin is 7 to 10 gram per deciliter. And severe anemia, that means hemoglobin is 7 to 5 gram per deciliter. And very severe, which requires prompt action, that hemoglobin is less than 5 gram per deciliter. Let us see that what are the clinical features of anemia, which as a clinician we should be aware of it. Most common is pallor. Sometimes parents themselves notice and the child is brought to you. They may complain of tiredness, easy fatigability, weakness, lassitude, sometimes behavioral changes, child may be irritable, occasionally excessive crying. Some children of toddler age group may go for temper tantrum. Even breath-holding spell may be precipitated by iron deficiency anemia. There is a very significant decreased cognition, decrease even the school performance, even poor academic achievement in older children or adults, exercise intolerance, and if it is of very long duration, it can also cause growth retardation. If we as a whole think what are the common causes of anemia, please keep in mind the main principles. Mainly there are 3 broad categories. Is it due to the decrease or inadequate RBC production in the bone marrow? or really there is some significant cause for the blood loss or increased destruction of the RBC. These are the three main categories which one should consider. If you feel that it is due to the decreased RBC production, and if it is hypoplastic bone marrow, again it can be of congenital or acquired. Congenital conditions which we come across in the practice are Diamond-Blackfan syndrome in the infants, Fanconi's anemia in older children, and various bone marrow failure syndromes. While acquired causes where bone marrow is involved and there is a decreased RBC production, maybe due to very common due to the viral infections, some drugs, or even the radiation may cause this bone marrow involvement. Blood loss may be obvious or sometimes may be the occult. Maybe due to some trauma, GI tract bleeding due to the portal hypertension, inflammatory bowel disease, or even cow's milk protein allergy. Maybe even the worms infestation like hookworm, which causes continuous daily blood loss, depends upon numbers of the worms. And even the hematuria occasionally may be responsible for the loss. Whenever there is this increased destruction of the RBC, there is always hemolysis. That may be the congenital again or acquired. Congenital can be due to the various hemoglobinopathies, due to the defective protein problem with the hemoglobin synthesis. Common conditions are thalassemia and sickle, which we can remember. RBC cell wall defect may be there, like hereditary spherocytosis, maybe the enzymatic defect like G6PD deficiency, pyruvate kinase deficiency, or even the autoimmune hemolytic anemias. Or acquired causes may be due to various regions like malaria, Kala-Azar, hemolytic uremic syndrome, infections, maybe even the viral or bacterial. Even the mycoplasma has been recently noted as a common cause in the practice. Please remember, among all these causes, hemopoietic deficiency factors is the most common. And these are the iron deficiency anemia, or maybe due to B12 deficiency, folic acid deficiency, or even occasionally thyroid deficiency also may be responsible. Frank, having this, let us see what are the various types of anemia in the practice. Acute anemia, suddenly develops anemia, most commonly due to the hemorrhage. That hemorrhage may be the external or internal, or maybe the sudden hemolysis in the case of falciparum malaria, or G6PD deficiency precipitated the hemolysis by some drug or some other factors. Autoimmune disorders, yes, can cause a sudden hemolysis, or presence of icterus suggests that there is a hemolysis or internal hemorrhage. May present even with signs of congestive cardiac failure, acute anemia, because heart does not get the sufficient time for the compensation. Chronic anemia may be the recurrent hematomesis in a case of portal hypertension, occult blood in the stool, maybe due to worms like hookworm infestation, inflammatory bowel disease, cow's milk protein allergy, or even chronic hemolysis in particularly the tropical countries due to the malaria. Insidious onset of anemia of very long duration sometimes may be asymptomatic in spite of hemoglobin even around 3 to 5 gram per deciliter. On the history taking, please start from the history of age. In neonates, always check is there any blood loss like hemorrhagic disease of newborn, fetal hemorrhage, kyphelohematoma, even in the prematurity, may be the responsible for the anemia, hemolytic disorders like Rh and ABO incompatibility, maybe hereditary spherocytosis, malaria, etc. Older children, nutritional cause is the most common. And for iron deficiency, most common age is 6 months to 3 years. Even beta thalassemia most commonly presents at the age of 6 months or second part of the infancy. But alpha thalassemia may present as anemia or hydrospitalis just after even the few days of the birth. Congenital bone marrow failure syndromes like Diamond-Blackfan, Fanconi's, and others can present in the older children. Family history check for the thalassemia, and particularly more common in certain communities like Punjabi, Loharas, Kachis, Khatris, and other specific communities. Sickle cell disease is more common in tribal community. History of hemolytic anemia suggests thalassemia, hereditary spherocytosis, G6PD deficiency like conditions. Repeated history of blood transfusion in the family suggests some hemoglobinopathy or bone marrow failure syndromes. Therefore, when it is very important, please prepare the pedigree for minimum 3 generations, and that may reveal that it is the X-linked disorder. There may be the G6PD deficiency. If it is autosomal recessive, thalassemia is more common, and really autosomal dominant may be the hereditary spherocytosis. Even the consanguinity is important because all of us know that with the consanguinate marriage, autosomal recessive disorders like thalassemia is common. Please remember, go in the details in the family history. And if you get this neonatal hyperbilirubinemia which required phototherapy for a very long time, jaundice, or even the splenomegaly, or there is history of splenectomy or gallstone in some members in the family, it suggests some hemolytic anemia like hereditary spherocytosis, which is very common. Dietary history is very important, and in the infants and toddlers it is seen that when there is a predominant milk as the diet, particularly after 6 months, very specific complementary feeds are not started, and child is only on the milk, sometimes a liter in a day or more than that, and these children nutritionally weight point of view are good, but anemia is very significant, and that is seen in the infants and toddlers. History of pica may lead to the worms and iron deficiency anemia. Goat's milk, if it is there, may be due to megaloblastic anemia due to folic acid deficiency. Cow's milk may be the protein allergy and responsible for blood loss also. Excessive breastfeeding, exclusive breastfeeding the first 6 months, all of us know that it is a protective factor for iron deficiency anemia in infancy. We know that B12 deficiency is more common in the vegetarians, and somehow folic acid deficiency is seen in the non-vegetarian people. Massive hematemesis always leads to the portal hypertension, while painless, massive bleeding per rectal may be due to the polyp or Meckel's diverticulum. Please, if requires, check this stool for occult blood consecutive for 3 days, and if it is positive, maybe in a case of inflammatory bowel disease, Ocon infestations, or portal hypertension. Skin bleeds and fever may be due to the hypoplastic or infiltrative bone marrow conditions. Some drugs very important like chloramphenicol, non-steroidal anti-inflammatory drugs may cause hypoplastic bone marrow. Cephalosporins and alpha-methyl-dopa are known to cause the hemolysis. Primaquine, nitrofurantoin again will precipitate hemolysis in a case of G6PD deficiency. Pyrimethamine and phenytoin are known to cause this folic acid problem and megaloblastic anemia. Infections, all of us know that malaria, Kala-Azar, chronic some infections, or even bacterial endocarditis may be responsible for anemia. Physical examination, check all of the vital, check for the signs of cardiac failure, check the blood pressure, maybe suppose severe anemia and hypertension, maybe chronic renal disease, or adolescent girl may present with the SLE. Look even the for specific phases, hemolytic phase, hypothyroidism, which will be the spot diagnostic feature. Check for the jaundice. Even the occasionally blindness may be associated with anemia in a case of osteopetrosis. Check the nails, platinacea, and if it is the iron deficiencies of very long standing in the older children, you may get the chylomicria. But anemia and clubbing together, I think it's very important clue for certain conditions like celiac disease, inflammatory bowel disease, bacterial endocarditis, or AV fistula. Lymphadenopathy leads to leukemia, lymphoma, HIV, tuberculosis, Epstein-Barr viral conditions. We know that anemia and hepatosplenomegaly together, keep in mind malaria, Kala-Azar, hemolytic anemia, leukemia, portal hypertension, tropical splenomegaly, HIV, etc. Bleeding manifestation indicates hypoplastic or aplastic bone marrow and or even the malignancy. Mucosal bleeds or mucosal changes, particularly you should check for the glossitis, angular cheiliosis, bald tongue, maybe even due to the hematopoietic factor deficiency like iron, B12, folic acid. Skeletal changes may be the like absent radius with the TAR syndrome, bifid thumb or triphalangeal thumb, maybe with the Fanconi or even the diamond black fan syndrome, or even the other condition like disc keratosis congenita. Skin changes always check for the pallor, glucose nutrient deficiency, hyperpigmented knuckles may be associated with B12 and folic acid deficiency in a case of megaloblastic anemia. Generalized pigmentation may be in a case of Fanconi's anemia. And non-healing ulcers, particularly over lower limbs, commonly seen in sickle cell disease like hemolytic anemia. Please always check for the Palmer pallor. No pallor, that means no anemia. You can check with this particular examiner who is non-anemic. If there is Palmer pallor, but creases are pink, it is some anemia. And Palmer pallor with even creases are also pale, that indicates severe anemia. Very simple but very reliable sign which even we can train to our non-paramedic, I will say non-medical people, and this is the very common picture which can show to them. So friends, whenever you come across any child with a pallor, first check the hemoglobin and hematocrit. If hemoglobin and hematocrit are found normal, that means there is no anemia. And cause for the pallor is something else. That may be in a case of decreased perfusion, peripheral vasoconstriction as I was talking, or maybe in a case of hypothyroidism, or in a case of edema like nephrotic syndrome. But really hemoglobin and hematocrit are decreased, that means it is anemia. And once you decide it is due to the anemia, and there is no hepatosplenomegaly, no lymphadenopathy, look for the petechial purpura, ecchymosis, and some bleeding tendency. Suppose there is the evidence of the bleeding tendency, think for the aplastic anemia, DIC, ITP, even the bone marrow dysplastic syndrome, or even maybe the coagulation or bleeding disorder. But if these manifestations of bleeding are absent, that means most common cause is the nutritional, maybe the iron deficiency anemia, maybe the megaloblastic anemia, or maybe even some rare condition like lead poisoning, or even the condition like thalassemia minor, G6PD deficiency, like that. And if you find the lymphadenopathy and hepatosplenomegaly present but there is no bleeding manifestations, then most common reasons may be the thalassemia major, even the hemorrhagic some hematological conditions, maybe the hemolytic anemia, some liver disorders, leukemia, myelodysplastic syndrome, malaria, tuberculosis, Kala-Azar like infections. And if you find the anemia with hepatosplenomegaly, lymphadenopathy, and even petechial purpuric spots, please look at the child, sick looking child, most commonly leukemia or myelodysplastic syndrome. Maybe the infection, DIC, even the myeloproliferation disorders, etc. So with this very simple approach, in a case of Pallor, you can decide whether are there any various conditions presenting as anemia or something else. Thank you very much. Friends, before I end, I request you to subscribe over this channel, and if you subscribe every time, you will get some new informations very useful in the exams and in the daily practice. Thank you. Thanks a lot.